skip one of the cases because we hopefully will be able to have the perspective of EMS on the pre-hospital side of the care. So thank you for attending case reviews for September. So as always, this information is confidential and privileged. It's protected under the law of HIPAA, and that you should not be using it, distributing it, or copying it to anybody outside of our organizations. So we're going to go to case 2. This is a case of a 67-year-old male that EMS was contacted. Initially, it was a contact for a fall with a subsequent left-sided chest pain. The patient was alert. His airway was open. He was protecting it, and his skin was pink, warm, dry. There's no signs of active bleeding. Vital signs were obtained within the first 2 minutes of patient contact. He had a heart rate of 77, and a blood pressure was not obtained. Just as a reminder, if I report whatever the vital signs are within 10 minutes, so I don't believe that the blood pressure was obtained in the 10 minutes of first contact. Respiratory rate was recorded at 24 and SpO2 of 100. Past medical history is that this patient has a history of alcohol abuse, depression, and substance abuse that was not specific, and that the medications that were obtained for his past medical history included hydralazine, Prozac, and trazodone. He states that he's an alcoholic and he drank heavily until last night, and that 3 days prior to his last drink, he had fallen and he has chest pain now. Oh, I apologize. I did record a blood pressure within the first 10 minutes. But anyways, this occurred at 9:50 in the morning. The initial vital signs as reported, and another set of vital signs at 6 minutes. His heart rate 68. His blood pressure is recorded at 145/75. He continues to be tachypnic at 24, and his SpO2 is 100%. He had told EMS he didn't want to go to the emergency room. He had said that his son was on his way to take him to the emergency room. He just didn't want to go by EMS, and he refused care, signed paperwork, and that until his son arrived, his roommate was going to keep an eye on him. And of note, the documentation at some point had stated that his roommate had actually called 911. So EMS left at 16 minutes. There was a full set of vital signs that were obtained, so that's excellent. They did document a physical exam, and that areas for improvement with the patient complaining of chest pain, even if we're considering it as potentially being traumatic, is that we should get a 12 lead. We recognize that this patient has abnormal vital signs, even if they're subtle, such as tachypnea, and further investigation of what caused him to fall. If it was obtained in the history, it should be written in our documentation. As a reminder, we care about how or why a person falls, as they're very different management workups for syncopal episode versus mechanical fall versus neurological deficits, and that the documentation was pretty minimalist in that if we should be recommending immediate medical evaluation for a patient with a complaint, and especially with a mechanism and abnormal vital signs. So we cleared from that scene, but we got another call about him a few hours later. This time, the complaints are chest pain, shortness of breath after a fall. He hadn't fallen again, but he had presented to an urgent care with these complaints. Primary surveys that the patient is awake, his airway is open, but he's still tachypnic. His skin's pink, warm, dry. There's no signs of active bleeding, and that he was pretty tremulous per the managing provider. They obtained a set of vital signs within the first 2 minutes. These ones were complete. He had a heart rate of 73, a blood pressure 151/74, a respiratory rate of 40, and they documented his weight to be about 90 kilos. Similar history provided. He has a history of alcohol abuse, but he also has a history of AFib, unknown if he's on thinners, and a history of cardiomyopathy, gout, and depression. The medications were a little bit more robust with atorvastatin, fluoxetine, hydroxyzine, metoprolol, and trazodone, and that he came to urgent care for the initial complaints that were described earlier, but the provider noted that he was in respiratory distress. They admitted again that the patient states his last drink was the previous night and that he had reported that he wasn't on blood thinners. So at 1 minute, those vital signs that I reported to you guys, they noticed that the patient's on the exam chair and that he was complaining of hurting all over, as well as difficulty with breathing in, and that he was nauseated. They obtained a 12 lead, which they documented was difficult due to his tremulousness. His respiratory rate at that point was recorded as 14. Just earlier noted that it was 40, and his end tidal CO2 was 14 millimeters of mercury. His 12 lead is what appears to be narrow complex, no evidence of STEMI. An IV was established. He got a small amount of IV fluids. At 7 minutes, his blood glucose was checked, which was 190. At 8 minutes, he was given 8 milligrams of Zofran. Physical exam was notable for abrasions across his chest, as well as the sides of his chest, but no crepitus was noted. At 13 minutes, he had another set of vital signs. He is still not tachycardic, which might be related to the metoprolol, but maybe not. His respiratory rate's recorded at 19. His oxygen is 100%, and this is on room air, and end tidal was 20. At 15 minutes, another set of vital signs, largely unchanged. At 16 minutes, he had a temperature recorded. He was not febrile. And at 20 minutes, another set of vital signs recorded, still not tachycardic at 71, a respiratory rate of 32, and SATs recorded at 100% with an end tidal of 15. They initiated transport at 23 minutes from urgent care. They contacted Peace Health for trauma consult, so not a modified or full trauma, but trauma consult. And 27 minutes, they got another set of vital signs, pretty stable from the previous, not tachycardic, still hypertensive, still tachypnic with a normal SAT and a low end tidal. And they arrived at the hospital at 32 minutes. I've been trying to include our Pulsera notification so that we can talk about if there would be any recommendations for changes in regards to those. So the notification to Peace Health was that they're coming in from Kaiser. He had a ground level fall 4 days earlier. He has a history of alcohol, and he is complaining of chest pain and he's tachypnic. And they record the vital signs that they obtained in there, and they make him a yellow. But the charge nurse makes him a trauma consult. So in reviewing the second case or the second presentation for the same patient, early serial vital signs, 12 lead, documenting that it was suboptimal, not because of a lack of effort. They obtained an IV, they checked a blood glucose, they got a history of the present illness, and they documented pretty well, and they discussed with Peace Health because of the criteria of should they go upgrade him or not. And I really had no areas for improvement for this crew. So in the emergency room, he reported that he had lost his balance. So the reason for his fall is he lost his balance striking the right chest on a curb. He had reported he did not lose consciousness. He didn't strike his head. So these are all things that were missing in our documentation of all, but I guess, and specifically in the first refusal. He had stated that he's been feeling intermittently lightheaded and dizzy, and that he feels like he might be developing withdrawal symptoms. Trying to remember. Okay, so while lightheaded, while the doc was evaluating him, he noted to be in VTAC, but non-sustained with multiple episodes of VTAC with torsades. They placed defibrillator pads on him and they gave him magnesium. So there's a 12 lead And this patient was roomed in room 30 once the provider evaluated him and noted that he was having runs of VTAC. They moved him to a front room. Um, and then the provider had told me that after they roomed him, they ended up defibrillating him because he had continued to be in VTAC without oh, there it's in there. So his cardiology was consulted. He started on isoproterenol drip because of his contraindications, and they planned to place him on a temporary pacemaker. He, while being evaluated in one of our resuscitation rooms, developed torsades and became unresponsive, so they defibrillated him at 200 joules back into sinus rhythm. And he also received Ativan for his alcohol withdrawal. He was admitted to the ICU. He had a temporary venous pacemaker, and he was treated with propranolol beta blocker. His fluoxetine was changed to Cymbalta because they thought that what might be contributing is the medication to his QTC prolongation, and he was discharged without any further issues during hospital day number 4. So I initially wanted to present this case because of the importance of gathering history and then serial or continuous monitoring for a patient that's considered high risk for developing an arrhythmia. I didn't know that he had 2 presentations during that day, and the pre-hospital side of things, even the trauma consult. So a moment to talk about torsades. This is a polymorphic ventricular tachycardia. It's associated with QTC prolongation, and depending on the gender of the patient, that might be 450 milliseconds for males or 460 milliseconds for females. Anybody with a QTC above 500 have 3 times the risk of developing torsades. Typically, it terminates on its own, but it can degenerate into the ventricular fibrillation, which we know we would be shocking them out of. Risk factors for developing torsades is that it can be acquired either from lack of nutrition, medication side effect, or it can be congenital where they're born with it. Usually that's associated with deafness, and hopefully we would identify that before EMS has contact with that patient, but that might be their first presentation. Older patients have a higher risk for having torsades, people with previous heart disease, and for whatever reason, female gender is a higher risk for torsades. The incidence is unknown, mostly because the patient might be lightheaded or dizzy or pass out or in cardiac arrest, and unless they've actually had their continuous monitoring prior to or during those episodes, there's a lot of missed opportunities to determine the incidence. And the pathophysiology for torsades is that there's an inhibition of the rectifier potassium channels. So there's a positive influx. Actually, I think there's a picture. Yeah. There's more positive ions within the cell membrane, which prolongs the phase 4 of repolarization, which means that they increase the chances for QT prolongation. And if they develop one ectopic beat on the R on T, then they are more susceptible to develop torsades or ventricular dysrhythmias. And the presentation for this, 10% or less of those patients with torsades will go into cardiac arrest. So that's reassuring. 50% of them will be asymptomatic. They'll terminate on their own. 50% will be asymptomatic and have no idea. And then the remainder, 40% may have a single episode, might feel palpitations or dizzy. So we get a lot of those complaints that end up, working up in the pre-hospital or hospital setting without a diagnosis, but this is something that should be on your radar, especially if they're at high risk, as mentioned earlier. So most of them are self-limited, meaning that they resolve on their own without necessarily any kind of interaction needed. If the patient's hemodynamically unstable, such as hypotensive, altered, then if they have a pulse, we cardiovert them. If they don't have a pulse, we defibrillate them. So in my personal experience, I've had one patient that I can vividly remember that was having a STEMI and had went into torsades. He was awake, and I thought initially that it was artifact. And I asked him, hey, are you okay? He's like, I don't feel very well. So that would be a patient that if he remained awake with a pulse, we would cardiovert, not defibrillate. But if they're not hemodynamically unstable, which that the patient I mentioned was hemodynamically stable, he looked pretty gray. Presuming that that's also related to hypotension. But if they're not hemodynamically unstable, then they would be treated with magnesium. So I thought this was a good opportunity to review our patient refusal of care. So it's for a patient that a medical need exists, but the patient is refusing or resisting care. You need to make sure that they have the decision-making capability of informed decision-making, and that if it's the patient or the decision maker for that patient, that they are informed of that if they are the patient or the decision maker, that you have to determine if they're not capable of making informed decisions for this incident. So if no medical need exists, a refusal form is not necessary. Documentation will include the events necessitating the call to EMS, as well as all criteria for no medical need. In that the disposition will be either patients evaluated, no treatment, transport required. If a minor medical need exists, a refusal form is necessary, and it must be completed by EMT or paramedic attending to the patient. Documentation should include all of the elements, which necessary elements in that disposition will be patient treated and released per protocol. And then this patient is a patient where immediate medical care or ambulance transport is necessary. So a refusal form is necessary, completed by the paramedic or attending that's attending to the patient, and that every effort will be made to convince these patients or their decision makers to accept necessary pre-hospital intervention and transport to definitive care. So given some options of how we would potentially persuade them using their family or friends, or potentially even law enforcement or mental health evaluators. Consultation with medical control is mandatory. So again, this is a patient that has immediate medical care evaluation determined, and that minimum, besides documentation, that we should also be contacting online medical control. And then in regards to his rhythm that wasn't identified in the pre-hospital setting, but could have happened at the pre-hospital setting, is that if, a reminder of our VFib, pulseless VTAC management. So our management does, not surprisingly, state that if the patient is pulseless, that we would shock them and that we wouldn't cardiovert them. And that if this patient was identified to be in torsades, they would not get amiodarone, they would actually get magnesium 2 grams. And then the same patient, if he has, presents with unstable tachycardia, but he has a pulse, we would synchronize cardiovert them if possible, pre-medicate them. And if they don't convert them because he's in torsades, he would get mag. Anybody have any questions, concerns, thoughts about this case?
I would just point out that alcoholic patients are more likely to have arrhythmias because of malnutrition, especially
Yeah.
hypomagnesemia.
Yeah, and he does absolutely correct, and that's where the electrolyte abnormalities, so like those social history, so that would also be, so he's at high probability because of his alcohol, as Dr. Mock has mentioned, but even our bulimics or our anorexics or our patients that have poor nutrition because of gut absorption, at an organic level, would be at risk. In talking with the doc taking care of this patient, we had discussed, like, is his potassium really low or is magnesium really low? And none of those were. So they really thought that the fluoxetine and his age and some of his other behaviors put him at higher risk for going into this. And so maybe he even, because I think what the patient had told the doc was that he lost his balance. So there was even question if maybe that reason why he fell was because of torsades.
Dr. Gadbois, there's a question in the chat.
Okay, I don't have it up if you wouldn't mind.
Okay. Yeah. So the question is, can we request trauma consult without an activation? And then the second part, I was told by a trauma doc, no activation if over 24 hours from time of injury.
So it's a good question. And I would say, so what I would say is that trauma has their criteria, but even in the hospital setting, we recognize that you can be critically ill and not fall into the trauma guidelines for our trauma surgeons. So that's why we have trauma consult in that and mostly because of the concern by the ER doctors stating that, hey, this, especially if you look at the trauma criteria, now there's even a time frame of I think like 4 or 6 hours from like falling and hitting your head on thinners. So we recognize that patients don't fall into our trauma criteria guidelines, and so when they don't fall into that, we ask, or at least the ER docs have asked, that we have a designation called trauma consult to relay the concern exists, but they may not meet the criteria that's kind of stringent that our trauma colleagues have put up. Does that answer the question?
Well, I just, to clarify from a pre-hospital perspective, is that we have trauma designations that are red or yellow. Use those as they exist. For us, there's no such thing as a trauma consult. That's hospital terminology.
Yeah, that's true. It's true.
Right.
And yes, and I, so the other side thing is that we recognize the pre-hospital side is that we don't expect you to know the terms we use and we try to do our best on the hospital side to recognize the terms that pre-hospital is using. But if you enter it as a concern for a red or a yellow trauma, or in the trauma category for Pulsera, and they don't meet the criteria, we still will meet you with concern, but we'll make it a trauma consult. So I think that you should still put in your concerns, in that the charge nurse's job is to make sure that it does or does not meet our trauma criteria. And if it doesn't, then it becomes trauma consult, which means the doc should be there, an ER doc.
Right.
But for EMS, the simple answer is always the easiest, which is if you believe the patient fits trauma entry criteria, red or yellow, enter them as that. Also, there is no time limit on it. You're not responsible. Let them know. Let the hospital know that the patient fell 4 days ago. But that doesn't mean that they're not still, in your judgment, a trauma entry patient. Let the hospital then make the sorting out of it.
Yeah, I mean, we know that there might be delay in presentation to a patient, or that the patient changes and that they don't necessarily, like I mentioned before, is that it's pretty strict criteria for our trauma colleagues, but it doesn't mean that we don't recognize a patient being a trauma, a patient suffering from trauma that's significant. So just put it into the Pulsera as a trauma entry, and our charge nurses they've been very good at identifying when trauma consults versus meeting the criteria of our full or modified or red or yellow, or we'll sort through it, put it in as what your concern is.
And I guess the last question to clarify that, is it helpful to you to get a call from the crew on a patient that's like this, or would you rather just get the Pulsara report?
No, so I would say that I would say put it in Pulsera, and if you feel that the response that you're getting back from the charge nurse is missing the point, then call. But most of the time, if there's ever a question that the charge nurse has, they come and talk to any of the ER docs that are sitting next to her or him and discuss it. And if we have a question, we'll ask them to call us. But I think that there's no need to call on every one-offs unless you're finding that you're getting like told to go into triage, or that you're getting some type of response that seems not what you'd expect. Does that answer that question? Anyone have new questions with this too?
That answers my question.
Alrighty. Well, if that's the case, then we'll go back to case 1. And we'll have, it's a 20-year-old male involved in a motor vehicle crash. If I can have paramedic Costa unmute herself so that she can present it.
Hey guys, can you hear me okay?
Yes.
Yep.
Okay. Great. Well, good morning. I apologize for not being here right on time. I work nights and my alarm clock did not seem to wake me up, so I apologize. So I was asked to present this case. We ran this call a couple months ago, a month ago or so. We got the call for an MVA, and it was a ref of like 160, or I'm sorry, 192nd area. And it came out as just a motor vehicle accident, unknown occupants. And initially another crew got toned out before we did. We were reading the notes and it was like, oh my gosh, there's going to be quite a few patients on this. So we started slow rolling out that way, and then immediately got upgraded to respond to this call. So we got there as the second responding AMR unit. There was a lot of fire department. There were a lot of law enforcement on scene by the time that we got there. And it was a fairly chaotic scene, although everything was being held down really well. There were quite a few patients, but as far as our patient goes, I'll continue on for our patient. We arrived on scene, got out of the ambulance, and were directed immediately towards our patient, who was, I think he was like 19. He was approximately 19, 20 years old. He was lying supine on the ground. Initially got out of the ambulance, walked up it was very dark. And we saw him lying supine on the ground. At that time, fire department had been putting him onto a backboard. Initial GCS was 3. Somebody was doing a very deep sternal rub with no response. Initially, he walked up and looked just did a quick body systems review, and almost looked like he was missing one of his feet. It was like, okay. And so then somebody had a flashlight and we kind of did a full view of his body. And we noted that obvious injuries was a complete degloving to, I believe, his lower left foot. Yeah, it's on there. So initial GCS was 3. We did get him onto a backboard very quickly, and got him into the ambulance. And as soon as we got him into the ambulance, his GCS improved initially to about a 14. He was still confused, but was following commands, screaming, yelling, saying he was in pain all over. We got the first IV within 4 minutes. I mean, it was a great collaboration between us and fire at that point. We got him into the ambulance and we were transporting by 5 minutes. I mean, it was really, really well maintained scene. So what I did note was the bilateral orbital swelling. So we were suspecting head injury. So let me back it up. So initially the notes heading to the scene had said that there was multiple patients involved in this, that there was a fire that had started in this vehicle, and that a Chevron employee had seen this accident and heard the accident, called it in, had noted that there was a fire, took a fire extinguisher to the vehicle and put the fire out that had started. So the injuries noted were the bilateral orbital swelling. We had superficial lacerations to his face, abrasions to his left upper extremity. Again, that lower left foot was completely degloved, and throughout my career, I've seen a lot of deglovings. However, this one was pretty spectacular in that sense. It was a complete degloving of the left foot. It appeared that the skin was even still intact. It looked like somebody just kind of took a sock off of a foot and left it hanging. It appeared that he did have a compound fracture of his tibia, as it was the foot itself was completely manipulated to a different side. I put that as it appeared what tarsals were left were black, and I just assumed, and I'm not for sure, again, because we had such a short amount of time with him, and I was trying not to get sucked down that rabbit hole of, oh my God, look at this. But his tarsals looked black, and after talking with some folks after the fact, it had seemed that when the engine compartment caught on fire, that perhaps it actually had burned his tarsals, his remaining tarsals. There was no need for any tourniquet. The bleeding had stopped, and so there was question of whether or not that had just cauterized that bleeding, because there was no real active bleeding to that massive lower extremity. So again, his GCS improved to 14 initially, and then it started to kind of trend down within, again, the very short amount of time that we had. So we did have to restrain him. He did admit to being the driver, but he was confused to events and time and whatnot. Lots of yelling, lots of screaming. We did have to restrain him as he continued to keep grabbing for his C-collar. We tried to be like, please stop grabbing for this. We're trying to help you. And he would stop for a moment and then continue to keep trying to grab for his C-collar, for obvious concern of C-spine. We made the decision to put him into soft restraints. CMS was present in all four extremities, post restraint as well. Pressures were good. O2 sat was good. Long sounds were clear. Sugar was good.
Hey,
We got yeah.
What do you think his SATs of 91% on that subsequent one was? Do you think that was due to artifact, or do you think that was accurate?
I would say it was due to artifact. Again, initially, our initial SATs were at 97%. And if I recall, again, it was a little while ago. So I think that might have just been artifact and moving around, because I do, had we have seen that it was 91, it would have been like, okay, let's, reevaluate this. But again, lung sounds were clear. He was having, positive CMS in distal extremities post soft restraint. So.
Perfect. Thank you so much for the pre-hospital perspective.
Sure.
And then, as you mentioned, a short on-scene time and arrival to the hospital, 19 minutes from time of arrival to the patient.
Yeah, absolutely. Yeah, we were beating feet trying to get there. So.
Yeah. There was no pulsera for this. Basically, I assume, would that be because of the time to arrival to the hospital, that you guys were really moving and really didn't have the bandwidth to put it in pulsera, so you called on the radio?
That is correct. Yeah. So we had loaded the patient, and as soon as we started going, we ended up taking 14 up to Leaser. And so, at that point, we didn't have a name, necessarily a date of birth. So I called the hospital and I was like, listen, you've got big trauma coming in, and you've also got a couple more patients. Here's what we have. We don't have any vital signs for you yet. He is conscious, he is confused, and here's what we have so far, and we will be there here shortly. So they were definitely ready for us, and yeah, but it was too much time. It was myself and another firefighter, and it was just like, you know what, we've got a lot of stuff to do in a very short amount of time, so we just got on the phone and called them and kind of let them know. Yeah.
Perfect. Great. And just as a reminder, this was a MCI. So if I remember correctly, there were 4 patients coming from this crash. So there were a lot of people mobilizing in order to get ready for this patient and the other patients from the crash. So in just reviewing, what Paramedic Costa and her partner and the EMS crews were doing, I thought that the care was great. Spinal precautions, ABCs, early and serial vital signs, checking a blood glucose. There's no prolonged scene time for the transporting agency. IV access was obtained appropriately, entered into the trauma part of Pulsera, so it came in as a full trauma, and trying to manage a combative patient with a short duration to transport to the hospital, and documentation was excellent. I really had no areas for improvement in regards to the pre-hospital care and documentation. The only thing that I had, which is that the hospital said that there were no vital signs were given to them, but in speaking with Paramedic Costa, that was actually inaccurate in that it was probably just a chaotic scene, and the trauma surgeon hadn't noticed that the vital signs were given. Is that correct as well?
That is correct. Yeah.
Awesome. All right. So this patient had, when he arrived, he had a GCS of 12. He ended up getting intubated based off of likely anticipation of his course. They got a pelvic x-ray, and they noted that he had an open book pelvic fracture, so an abdominal binder was placed. He developed shock refractory to blood, so he got 2 units of red blood cells and 2 units of plasma, so they initiated the massive transfusion protocol and added to TXA to his treatment. The CAT scan of his head was negative. They did a CAT scan of his chest, abdomen, pelvis, and he had a small right pneumothorax. He had a grade 3 liver laceration. He had an injury to his descending thoracic aorta that was contained, and then he had a laceration to his external iliac artery on the left side, and he had a large hematoma in his pelvis secondary to his open book fracture of his pelvis. They did put a right chest tube in, given that he was intubated, and he got an x-ray of his left foot that showed severe tarsal hindfoot dislocation. In the emergency room, both interventional radiology and vascular surgery consulted based off of his pelvic fracture and hematoma and his aortic injury. At Peace Health, he went to the cath lab. He was stented and underwent angioplasty. He went to the operating room after the cath lab. They noted that he was acidotic and his CKs were elevating his creatine kinase. He ended up getting a left below the knee amputation and a 4-compartment fasciotomy of his left lower leg and thigh. He was started on continuous renal replacement therapy because of renal failure, likely from his hypotension, his rhabdo, and those are the major reasons that they thought that he was going into renal failure. And then he was started on a bicarb drip. On hospital day 2, he went back to the operating room because he was getting sicker, not better. They underwent exploratory laparotomy with abdominal washout and wound packing, as well as a wound vac. He went back to the OR again on hospital day 2 to get a left above the knee amputation and further fasciotomies to his left gluteal and medial compartments with a revision to his thigh, because he was becoming worsening kidney failure despite CRRT, worsening acidosis, and worsening rising creatinine kinases. I think ultimately the highest one I saw was 200,000 and change. On hospital day 3, he was transferred to OHSU for possible debridement, soft tissue coverage, and concerned that he might need to have half of his pelvis removed because of ongoing infection and ischemia, or ongoing ischemia that later determined to be potentially infection. So once he made it to OHSU, he underwent a reduced sternotomy. They reopened his laparoscopic incisions and did cochlearization of the duodenum. A peripancreatic drain was placed, and they IND'd or incised and drained his left lower extremity and placed an external fixator of his left pelvis. He returned to the operating room on August 15th for abdominal closure. He had a left above the knee IND with a wound vac placed. He would on August 15th, he also had a bedside arterial ligation for ongoing postoperative hemorrhage, and he returned to the operating room for a left thigh perforator ligation. August 17th, he had his left hip removed with extensive debridement up to the bony pelvis because of necrotic muscle. On the 18th, he had a left hemipelvis incision and drainage. On the 19th, he had a left hip washout and debridement with a wound vac. And can go on and on and on, but you can see that he had a lot of surgeries, and they ultimately believe the reason, besides the compartment syndrome of his left lower extremity and his renal failure, that he also had a necrotizing soft tissue infection of his left lower extremity into his pelvis, and that was why he was not getting better in addition. I looked up his course yesterday just because I think it was August 10th is that when this call occurred. They also noted that once he became more stable and was improving, that he was complaining of horrible pain in his upper extremities bilaterally, and so they determined that he had ischemic myopathy and neuropathy. They ultrasounded his upper extremities. He had bilateral clots, none of them that were extending, so he was on anticoagulation, and that he was likely going to develop Volkmann's contractures of both of his upper extremities. So both ortho and hand were in management of his care, as well as multiple other departments between vascular, general surgery, infectious disease. He had in the ICU care. On September 22nd, he was transferred to a short-term hospital for inpatient care, which I no longer can follow, so I hope that he's continuing to do better. But I believe, if I remember, that Paramedic Costa had said that she was able to reach out to the family and said that he was doing better. That he was, go ahead.
So my partner that I was working with that night, my partner's daughter is actually friends with all of the folks that were in that accident. So that's how I was kind of getting updates off of that. So it sounds like he's off of dialysis completely now, kidneys functioning properly. They're talking about the possibility of prosthetic leg for him with the GoFundMe money. And then there was something about another patient that was in there. So
okay, yeah, and then he was able to stop renal replacement therapy August 21st. So that's the dialysis portion of things. So excellent. Yeah, just a really sick patient that had a really tenuous course until they finally were able to stabilize him. So I thought this was a good opportunity to talk about compartment syndrome. I feel like we've talked about this before, so it might be a repeat reminder, but it's a condition when there's increased pressure within a closed osteofascial compartment, and that as that pressure increases, it prevents adequate circulation at the area that it's trying to perfuse, and that is considered a surgical emergency. There's nothing that the pre-hospital side of things could have done differently. This is more suspected and evaluated and treated aggressively once this develops or once it's suspected. So the etiology is usually trauma, but it can occur without trauma. And that 75% of the time it's due to fracture, especially tibial fractures, or crush injuries, burns, as well as vascular injuries, blood clots, and bleeding disorders. It can also be caused by reperfusion and infection, as well as iatrogenic, so IOs that get placed and aren't aware that they are actually extravasating into the muscle. And then intense athletic activity can also cause acute compartment syndrome. And then it is possible to occur in more than one location. Males are more likely to have this condition occur over females, and that's probably more related to their physical activity and then also the risk for trauma. and that they say that there's like 5 P's in regards to how the patient's going to present. The P's are going to be pain, pallor, paresthesia, pulselessness, and paralysis. So the most accurate early finding would be pain that is out of proportion, and that the compartment itself is tense. It's a diagnosis of clinical suspicion that can be confirmed with using a Stryker device, which would be placing a needle into the compartment and measuring the pressure. If the intercompartmental pressure is greater than 30 millimeters, then the concern for compartment syndrome is high, and that if it's less than 10, that would be normal. And treatment is going to be surgical. I think there's a picture. Oh, actually, let me just show. So this is a cross section of the compartments of the lower extremity along the tibia. So there's 4 compartments: superficial posterior compartment, posterior tibial, anterior compartment, lateral compartment, and treatment for a fasciotomy is to be able to gain access to all of the compartments and to allow release of pressure. So, but if this is a patient that you're concerned of lower extremity compartment syndrome, they would be potentially doing fasciotomies of all 4 compartments, understanding that the posterior tibial can be difficult, so you may end up having to do a deeper incision to reach that compartment. These compartments, they're contained with a fascia, and that as the pressure increases, you can see some of them have blood vessels, some of them have nerves, and that those compression doesn't allow for blood to circulate into the compartment, and also doesn't allow for waste products or carbon dioxide and all the other aspects in regards to perfusion to escape from that compartment. So surgical consultation would be part of the treatment, removing any other restricted devices and elevating the limb above the level of the heart to help with pressure, and then fasciotomies. This is an example of a fasciotomy of the lower extremity. So these are pretty large incisions that are not really based on cosmesis. It's more of saving the limb. We don't have any protocols in regards to compartment syndrome per se, but suspicion of compartment syndrome, and especially if we've got a patient that has been in a crush injury or restrictive or event, would put us at higher concern for compartment syndrome, especially with reperfusion. And that is all I have for that case. Any questions?
Just say thanks to Paramedic Costa for presenting. That was really, really good.
Yeah, absolutely. Definitely. All right. So for case 3, it's a 66-year-old male. EMS gets called for leg swelling, leg pain, and fatigue. Actually, that's what they documented. The transporting agency documented, but the initial call was to BLS for a sick case. But anyways, for the transporting agency, the patient was alert. His airway was open. He was protecting. His skin was pink, clammy, and warm to touch. There were no signs of active bleeding. The first set of vital signs, all of the vital signs grouped together in the first 10 minutes. He had a heart rate of 134, a blood pressure of 91/62. No respiratory rate was recorded, SATs of 98%, and he was approximately 90 kilos. His past medical history included anxiety, AFib, depression, and lower extremity edema. He didn't report any medications to EMS, and that the history of the present illness was that his legs were swelling for the last 2 years, secondary to lymphedema. His legs have been getting worse over the last few months, but and he hasn't been able to walk, so he was just wrapping bags around his legs to help with the weeping. This call came in for BLS at 6:23 in the evening. They contacted ALS, who arrived and initiated a sepsis alert within 2 minutes of their arrival. It's documented that the patient was seated in a walker in the living room, and the physical exam that he had documented was that his skin was clammy, warm. He had leg swelling from his knees down to his toes, and that his toes were caked with, and this is their documentation, with feces and animal hair. They noted that the left lower extremity had a black garbage bag around it. They removed that bag, and there were a dozen more bags wrapped around that left leg, and that about a half gallon of dark brown liquid pooled in the bag. They noted that his skin was swollen around a leather slipper and that it was breaking down, and that his skin was hard and scaly to the shins, that there was water logged in the bags along his feet, and that his skin was sloughing off. They obtained a 12 lead within 6 minutes. They got another set of vital signs. At that point, they noted that he was hypotensive and remained tachycardic. They contacted online medical control, which was me at the time, and they wanted to know if they should go to a manual because they suspected that his legs were so bad that he was going to have his legs amputated, and they were also concerned about long-term wound care, and that if this should be treated like a burn, so that they should go to a manual for that. And speaking with the crews, it sounded like this was not a trauma, and that this was, severe infection, concern for bacteremia, that this could be managed at our hospital, and that they should come here and we could stabilize him. And if we needed to transfer him out, we would. At 33 minutes, they obtained another set of vital signs: heart rate 120, blood pressure 104/64, respiratory rate still not recorded, and his SATs were documented at 98%. They initiated transport at 36 minutes. At 42 minutes, they placed an IV. They gave him 350 mLs of IV fluids. They got another set of vital signs: heart rate 110, blood pressure 128/60, so improving with the fluids and care. They arrived to the hospital at 54 minutes. So the pulsera for this patient was that there was going to be a yellow, and that they documented severe tissue breakdown of the left lower leg, secondary to chronic lymphedema and failure to thrive, probably in need of a below-the-knee amputation, rule out sepsis, which was very appropriate and spot on for what this patient had indeed. They noted that he was tachycardic and not as hypotensive as he was before, but clearly indicating that this is a patient that is highly probability for hypotension with a borderline soft blood pressure, and that his temp and his respiratory rate and GCS were reported, so it was very helpful. This is not a patient that I took care of. It's just that I was involved on the online medical control consult. So the good parts of reviewing this case was that the assessment was really thorough, as indicated in the physical exam portion of the previous slide. They got serial vital signs. They evaluated the leg instead of just saying the leg looks bad. They made an effort to evaluate the leg further to see what they're dealing with, which helped them in their decision making, if they should be going to a higher level than what Peace Health could offer. They got IV access, they considered their destination, and they did great documentation and had a really succinct, appropriate pulsera notification. The only thing, which is really minimal, is was it on there? No. Could we add an end tidal CO2, which might help you in kind of cinching that diagnosis of concern for sepsis? So in the emergency room at Peace Health, the physician who took care of this patient documented that he had bilateral leg edema, chronic stasis changes, areas of keratosis of the left lower leg, extensive changes of chronic lymphedema to bilateral feet, foul odor, hair, feces, and clothing in the wounds, and that the cap refill was normal. Pretty close, if not replicable to what EMS had documented. They documented that they're unable to appreciate pulses due to the swelling. There was no calf tenderness or swelling, and that they were able to get pulses with Doppler. X-rays of his left foot showed that he had osteomyelitis to the distal fourth metatarsal and phalange. His labs were concerning for an elevated white count, low hemoglobin, low potassium, and elevated markers concerning for infection. He was treated with broad spectrum antibiotics, and he also got a blood transfusion based on how severe his anemia was. The picture on the right is a picture that was included into his chart because of the condition of his feet. So that's what EMS was looking at. And they attempted to transfer the patient to a manual, not because of a trauma indication, but one thing that EMS wouldn't be aware of is that recently our orthopedic colleagues are no longer doing foot amputations. So for us, we have to get our vascular surgeons to agree to do that. And that is a hit or miss. And so I guess initially there was concern that vascular wouldn't do it. And then once there were no beds at Emmanuel, vascular agreed to be able to keep him and take care of his amputation. So he ended up getting a CT angiogram of his aorta, which showed that he had left anterior tibial artery occlusion, which was probably contributing to his poor wound healing and his edema. On hospital day 3, he had a left below the knee amputation with a wound vac and a right tarsal metatarsal amputation as well. And then on hospital day 11, he got a left below the knee revision, as well as a closure of his right foot, and he was discharged on hospital day 32 to rehab. Any questions?
There's a request to zoom in on the picture, so we can see more clearly what's going on there.
Yeah, hold on. Ooh, there we go. Need to. How's that? So I guess right foot, great toe, some of his other phalanges, left foot. His diagnosis, at least based off of previous encounters, is that he had elephantitis of his lower extremities. So there were some chronic changes that were pretty severe to give him a diagnosis of elephantitis. But you can see that he's got, and the other thing too, which I didn't mention, is that when they removed the bags, there were maggots as well.
It's keeping the wound clean.
Yeah. All right. So I thought this was a good opportunity to talk about osteomyelitis. So this is an infection of the bone due to pathogenic microorganisms that can be bacteria, that can be fungus, or whatnot. And then the etiology is when there's introduction of bacteria by way of either direct blow from trauma, foreign body that has entered the area, or from ischemia. The incidence is reported to be 1 in every 675 hospitalizations in the United States per year. And the risk factors increase with older age, more likely in men, and immunocompromised states such as like diabetes or peripheral vascular disease. The pathophysiology can be either hematogenous, so spread through the blood. In pediatrics, it's more frequently the case than adults. But when it does occur in adults from a hematogenous spread, they usually present with vertebral osteomyelitis. It can be either from direct inoculation, something that has entered and directly entered the bone and giving exposure to bacteria, or from contiguous spread. You have an infection of the skin or soft tissue next to a bone that has spread to the bone. In younger adults, it's usually the etiology is going to be trauma or surgery, iatrogenic, and in older adults, it's usually due to contiguous spread, such as like decubitus ulcers. And then the history and physical for these patients, really you're going to be looking for high risk history. So these are patients that are diabetics, dialysis patients, taking immune modulators either from organ transplant or because of autoimmune diseases. They're also going to be IV drug users, non-compliant folks, people that have poorly healing wounds, or previous orthopedic hardware that remain in their body. And when we're reviewing of this, there's acute and chronic, but interestingly enough, some of the bacteria like Staph aureus has created or developed a system to adhere to the bone or the hardware, so making it very difficult to eradicate even with even with long-standing antibiotics, so that they can present with this infection in the remote future. So the hospital evaluation for these patients, let me get my is going to be labs. They're going to be looking for signs of infection or inflammation. So we tend to get lots of labs, but specifically looking at CBCs, lactates, ESR, CRPs. We get blood cultures on these patients when we're thinking about osteomyelitis. And that we sometimes get x-rays, but it's not so much that we're looking for osteomyelitis on x-rays, because it could take up to 14 days to identify osteomyelitis via this imaging study, but really looking for other causes for why there might be pain and swelling. So looking for fractures or metastatic disease. And then we tend to get MRIs more later in the course of like maybe during the emergency room presentation, but usually during admission. These ones to help our colleagues that are going to be considering amputation to see where the destruction of the bone is extending to, and that MRIs are sensitive to picking up osteomyelitis from wounds up to 5 days after, or within 5 days of onset of this condition. And that these patients also tend to get bone biopsies to confirm the bacteria that this patient is suffering from, as well as determining the sensitivities to antibiotics. So treatment for these patients are going to be prolonged antibiotics in ways of weeks to month, and then surgical containment, which usually ends up being amputation of a section or of a joint, a section like is a small area versus up to a joint. And then these patients will have multiple other focuses for their care, such as revascularization. This patient that we talked about had a thrombosis, management of chronic diseases such as like diabetes, and then modification of social history, making sure that the wound healing, so diet, nutrition, are going to be optimized. This is a picture of osteomyelitis. The first one, A, showing an abscess, and then how this breaks down to subacute into acute osteomyelitis versus as well as chronic. I think there's another picture. Yeah. And then this is a picture of how this patient may present. There may be a wound. There will be likely a wound or some discoloration of the skin. You may see redness around it. If it's like an acute one, you may not see much of any redness around it with chronic osteomyelitis. From the data, having a tract that tracks down to the bone is usually pretty high probability for osteomyelitis. I would not recommend putting a Q-tip or anything external in the pre-hospital setting to see if the wound tracks to the bone. We don't have any guidelines for osteomyelitis or bacteremia, but we can look at it as a septic patient in our protocols locally. Anybody have any questions, thoughts?
Excellent presentation. I particularly agree with you that it would have been nice. It would have been a nice addition to the evaluation to have not only respiratory rate, but to have the CO2 recorded. CO2 is terribly underused right now because it's going to give you a tip and a drive you toward the diagnosis of acidosis, whether the patient's in sepsis, whether they're in renal failure, whether they're in whether they're in DKA. If you have a patient with an elevated glucose of greater than 500, they're awake and talking to you, and they have a normal CO2, it's unlikely they're in DKA.
Yeah, and just like Dr. Whitwer is mentioning, you're looking, if you are looking for these conditions like sepsis or diabetic ketoacidosis, we would be potentially seeing metabolic acidosis. So our end titles should be low as the patient is compensating. Awesome. All right. Well, our last case, thank you guys for your time and attention to this. This one is of a 41-year-old male who EMS got for vomiting blood. EMS was dispatched to a potential gastrointestinal bleed. The patient was alert. He had his airway was open and he was protecting it. He was jaundiced. He had a pulse. He was tachycardic and he was vomiting blood. So initial vital signs obtained within a minute of patient contact, no heart rate, but blood pressure of 151/123, respiratory rate not recorded, and SpO2 of 99. This is FIRE's vital signs. Past medical history was that he has a history of alcohol abuse, he has a history of end-stage liver disease, and he has previously had kidney injuries. He was unable to provide any medications of his that was prescribed to him. And the history that he provided was that he started vomiting this morning. It was dark in color and looked like coffee ground. He also stated that he was recently admitted for surgery because of his GI bleeds and was discharged 3 days ago. So transporting agency arrived at 5 a.m. The patient at 10 minutes got an attempt for an IV, and at 13 minutes he got his first IV and he was given 400 mLs of IV fluids. They found him in the right lateral recumbent position on the ground. He was lethargic, poor skin signs, jaundice, scleral icterus, pale, and they noted that his abdomen was distended and they felt was rigid. He got 8 milligrams of Zofran at 15 minutes, and at 16 minutes, they obtained another set of vital signs, but only the blood pressure and the blood glucose, noting that he was pretty hypotensive at 63/35, glucose, which was 165. At 17 minutes, they obtained a full set of vital signs. Heart rate's 103, still hypotensive at 63/36, respiratory rate 19, SATs of 94%, end tidal is 20. They left the scene at 21 minutes. At 23 minutes, they placed him on 2 liters nasal cannula. Oh, I apologize. And they got a 12 lead. Let me just get that for you guys real quick. It really just showed sinus tachycardia from my recollection. No other abnormalities, but I'd like to zoom in for you guys to also come up with that as well. Okay. So pretty artifactual, but narrow complex, looks a little tachycardic, no clear signs of an arrhythmia. He vomited with EMS that was bloody. He was complaining of abdominal pain, and he had stated that it's been over a month since he last drank alcohol. They got another set of vital signs. His blood pressure is improving. Oh, actually, I should mention, before they transported the patient, the documentation is that fire insisted to move patient in a stair chair. They stated that he syncopated with standing, so they moved him with a mega mover. So I'm not quite sure if that's because they felt that he shouldn't be moved in a stair chair or they should have walked him, but either way, any change in position for this patient was that he ended up passing out. So it was very hemodynamically unstable. So he responded to IV fluids with an improvement in his blood pressure of 81/45. 29 minutes, they reobtained another set of vital signs. Heart rate's improving from 109 to 103. Now blood pressure is 151/125. Respiratory rate of 26, and they document a SAT of 79%. They don't document that they placed him on oxygen or mention why his SATs are now recording at 79%. At 30 minutes, they obtained another set of vital signs. He has a subsequent drop in his blood pressure to 71/37, his respiratory rate of 24, and end tidal 23. They arrive at the hospital 15 minutes. So the pre-hospital notification is that this patient's a yellow, that he had underwent surgery on July 27 to fix a GU bleed, but this is probably a typo for GI bleed. He was vomiting blood and was hypotensive, pale, and jaundice. They document a heart rate of 101, a blood pressure of 63/36, a respiratory rate of 24, and a SAT of 97%, and a GCS of 15. So assuming this was before he became hypoxic, based off of what EMS has for history of present illness as well as past medical history and his vital signs, I would say that this is a red patient, not a yellow patient, which is what the charge nurse had determined prior to the patient arriving. She had upgraded the patient to a red, which I think is appropriate, especially as his course in the ED unfolded.
Agree.
So the good here is that IV access was obtained, serial vital signs were obtained, he got some antiemetics, they documented past medical history as best as the patient was able to provide, and they documented pretty well. Full set of vital signs within 10 minutes would be ideal, especially as it was late to find out that this patient was pretty hypotensive. If time allows, getting a second IV and a hospital notification being that this patient would be better served as an upgrade to a red as opposed to a yellow patient.
Great, excellent work on getting the CO2. CO2, he's a metabolic acidosis.
Yeah, absolutely. So this is a patient that I took care of. So I ended up changing up how I present that follow-up because I can speak to a lot of it. So his vital signs when he arrived, he had a heart rate of 114. He was soft in regards to his blood pressure of 106/66. His respiratory rate was recorded as 40, and his SpO2 was 75%. I would definitely say the patient was short of breath, but I think that his SATs were more related to vasoconstriction of the periphery and that we weren't getting a very good SAT. Once we obtained a core SAT, which is something that the pre-hospital is not capable of doing, we were able to get a better, actually a normal SAT with this patient. And that's something that you can identify in the pre-hospital setting if you find that the patient's skin is cold, like in his fingers, or there's maybe cyanotic or pale. Those would be suggestions that the patient is shunting to his core and very concerning for shock. So within evaluating the patient, we started him on octreotide, Protonix, ceftriaxone for prophylaxis against spontaneous bacterial peritonitis, as well as getting blood for him. His point of care hemoglobin was 6.1 and his lab hemoglobin came back as 5.3. He started vomiting blood. We were hoping that he was going to kind of be stable to be admitted, but he started vomiting blood in pretty massive amounts of blood. So we initiated a massive transfusion protocol. Ultimately, this patient, through his course, got 21 units of blood, 50 units of FFP, 2 units of platelets, and 1 unit of cryo for that massive transfusion protocol. And he also got TXA, which is further down. Because he was now becoming hypotensive, we started on vasopressin. And I consulted GI, I think 4 times, talked to the ICU, and later talked to interventional radiology within, I think, 25 minutes because he had actually been admitted to the hospital 2 times earlier this month and had been banded. So they really felt that additional banding and recent scope with banding wasn't going to be beneficial and actually could be potentially risky for this patient. So they wanted him to be considered for a TIPS procedure. And we've talked about that in case reviews previously, so I'm not going to go into great depth unless someone asks specifically. I talked to the pharmacy about TXA for this condition, and ultimately we agreed that that would be beneficial for him since he's having ongoing bleeding, and he was having ongoing bleeding, upper and lower GI bleed. He probably vomited 6 more times, probably 2 liters of blood in bags of emesis basins. So I didn't think that we were going to be able to get away from not protecting his airway because he was becoming increasingly hypotensive, now a little bit altered, but not horribly. So at 52 minutes, we decided that he should be our side. We got his consent. He wasn't incapable of making decisions about his care. And he had asked that, so the reason why there's 52 to 69 minutes before we intubated him or tried to intubate him was because he wanted to talk to his wife to say his last words to her in case he didn't wake up or died from his condition. So I felt that although I really wanted to protect his airway, I didn't want to take away his chance to say what he needed to say to his partner if he never got to say anything to them. So it was a stressful situation, but once he had said what he wanted to his wife, he became more hypotensive. So we spent the subsequent time between 52 and 69 minutes titrating up his pressors in order to optimize his hemodynamics before we intubated him. I anticipated him being a horribly difficult intubation given the amount of upper GI bleed that he was producing. So we had backup equipment, an iGel, Crike, and I notified the 2 other ER docs working about his possibility for a difficult intubation. I chose ketamine for the to try to make sure the induction agent didn't make him hypotensive, and rocuronium. Even though we had potassium levels back, I chose rocuronium for just making sure that we remained as stable as possible. We RSI'd him, but he started vomiting blood again as we were pushing the paralytic. I tried to do a salad technique. I couldn't only visualize his epiglottis the first time. The second time, it was just filled with blood. I got my partner to come in and try to intubate, which he couldn't see anything. So we tried to blindly intubate, which were 2 belly tubes. And ultimately he ended up getting criked in the resuscitation bay in our emergency room. Of note, he was bleeding so heavily that blood was pooling not only from his mouth down, but also from his rectum down onto our nurse's feet. And then we ended up placing a Blakemore to try to control his upper GI bleed. He went to the cath lab within 2 hours of his presentation for a TIPS procedure. He did get the TIPS, anesthesia endotracheally intubated him once his bleeding was no longer an issue to place a breathing tube, and they removed the crike prior to that to intubate him. He was able to get his Blakemore removed on hospital day 2, and on hospital day 3, he was able to be discontinued off of pressors, and they removed his ET tube, and he discharged on hospital day 5 to hospice. So this is a patient that I really want to stress that if you've got someone who's got this past medical history of like bleeding disorder, high probability for GI bleed, you already find them hypotensive and they're really not stable. You're finding hypotension again to upgrade them to a red because this kind of condition could occur. So there's a lot of things I could talk about in this case. We talked about end-stage liver disease and treatment of end-stage liver disease, and I didn't feel like that was great. I thought about talking about TIPS, but I think that what's more important for this case is intubation for massive upper GI bleed in the event that your EMS's hand is pushed to have to intubate this patient in less than ideal setting. So an indication, I would not electively intubate this patient unless you felt that there was really a concern for airway control. So they're obtunded, they're encephalopathic from their elevated ammonia or hepatic encephalopathy. You're concerned that they're going to aspirate. I would not admit them. I mean, I would not intubate them for hospital course in the pre-hospital setting. But if you are seeing this patient have a rapid deterioration from the moment that you made contact to them and while you're transporting, I would say that I would really consider that you may need to intubate this patient, but not as an elective procedure, just because of the awareness that this can be a very difficult airway. So once making that decision that you need to intubate the patient and moving forward, PPE usage should be maximum. As I mentioned before, he was having a massive upper GI bleed as well as a lower GI bleed at the same time. So these are patients that you want eye protection, you want a mask, you want a gown if you have access to it, because these can be a really bloody procedure. I wrote empty the stomach in like tiny font because that's really something like the hospital might be doing, and that we would be putting an NG tube or giving Reglan. We don't have Reglan to administer in the pre-hospital setting, so that helps with prokinesis and emptying the stomach. Pre-resuscitation, so getting access, giving fluids if that's all that you have, ideally blood, and then pressors if necessary. The head of the bed should be at 45 degrees to really improve the odds of if there's any type of blood in the upper pharynx, posterior pharynx to be gravity dependent. And then pre-oxygenating these patients with apneic oxygenation if they're not hypoxic and you're just trying to denitrogenate them. So really minimizing the positive pressure ventilation so you don't increase the odds of emesis. And if you ultimately have to bag them with positive pressure, that you do it slowly, like 10 a minute or less, as long as they're perfusing, and then really consider potentially using an eye gel if the patient is so obtunded that they would tolerate that. As regards to choice for induction and paralytics, really you want an induction agent that's going to be pretty hemodynamically stable for the patient, so ketamine's a better choice. Reducing the induction agent because of their critical illness by half dose, and that these patients are in desperate need for paralytics. Paralytics have been proven to increase the sphincter of the lower esophagus. So really, these are patients that you should not be bypassing paralytic administration to, because it's actually beneficial and helpful for your patients. And some studies I reviewed showed that they recommend twice the dose of paralytics. I wouldn't necessarily say that. I would just say that don't, at least in the pre-hospital setting, I would say make sure you're giving a paralytic to this patient, because it can increase the sphincter of the esophagus to decrease the chances of ongoing vomiting. Salads, so 2 suction devices, and using video laryngoscopy, ideally with DL as a backup, and eye gel and crike. So we don't have a protocol for GI bleed, upper or lower, but we do have a protocol for shock, and that patient would meet the criteria for shock, at least once he arrived to the hospital. But you could even argue that he already was in shock in the pre-hospital setting. There's no external bleeding to be managed, but fluids to maintain a MAP and make sure that your fluids are not detrimental to your patient. Any questions?
No, just one thought about the extrication. Obviously, like you look at this patient, you see the presentation. This is someone who's unlikely to do well sitting up. If your hand is forced and you're like, man, we're going to need to get another crew to get him supine, you can, before like getting him all the way up into the stair chair, you could try to sitting him up and see if he's going to tolerate sitting up. My guess is this patient's going to syncopize if you sit him up, and then you just know, like, we got to extricate him supine.
Yeah.
Yep, agree.
All right, thank you for that. So in review, we talked about compartment syndrome, recognizing that trauma might be the culprit, but it can also occur with non-trauma, and you're looking for really pain or tenseness and asymmetry. Second case we talked about was torsades, recognizing that something as subtle as lightheaded, dizzy, or syncope could be related to an arrhythmia, and that there's risk factors that increase the probability, so electrolyte derangements, nutritional, congenital, as well as medication side effects. So getting an EKG early and considering to keep them on the monitor. We talked about osteomyelitis and infections of the wound, how a patient might develop osteomyelitis, and that this is a picture more of a chronic osteomyelitis. So really not all that red swollen, but you have a defect. And so exposing the area to evaluate for risk of a severe infection like this would be indicated. And this is just a picture of the bone, the bone loss or breakdown from the infection that has extended from the external wound internally. And then we talked about upper GI bleeds or end-stage liver disease and the complexity of potentially needing to intubate and what things you can do to improve your odds for success. And that is all I have for you guys. Thank you so much for your time. We're 10:30 almost.
Thank you, excellent.
Thanks.
Thank you very much.